Maria Cecilia T. Layson, MD. Health Process Evidence-Based Clinical Practice Guidelines Acute Abdomen in Newborns. Rommel Q. De Leon, MD. Maria Cecilia T. Layson, MD. Operational Concept of Acute Abdomen in Newborn. Any abdominal condition from various causes involving the intra-abdominal organs that requires immediate/urgent intervention in newborn, 1 to 28 day of life. The two general categories of acute abdomen in newborn. Acute surgical abdomen, requiring immediate operative intervention. Acute non-surgical abdomen, requiring immediate non-operative intervention. What are common causes of acute surgical abdomen in newborn? Non-trauma. GI obstruction. GI bleeding. GI perforation. Abdominal wall defects. Trauma. What are the more common causes of acute non-surgical abdomen? Non-trauma. Ileus. Diarrhea. Neonatal intestinal obstruction. Patient with imperforate anus. Patient with perforate anus with. What are reliable signs and symptoms? More than 90% certainty that a newborn patient has intestinal obstruction. Patient with imperforate anus. Patient with perforate anus with. Abdominal distension. Persistent vomiting. Non-passage of meconium within the first 24 hours of life or non-passage of stool within 24 hours. Types of intestinal obstruction. Mechanical. No recent history of systemic illness prior to the presentation of intestinal obstruction. Non-mechanical. Recent history of systemic illness prior to the presentation of intestinal obstruction. Causes of mechanical intestinal obstruction. High obstruction. Gastric outlet obstruction 1 to 1 million live births. Pyloric atresia. Pyloric stenosis. Antral web. Duodenal obstruction. Jejunal obstruction. Duodenal atresia. Duodenal stenosis. Annular pancreas. Preduodenal portal vein. Malrotation. Jejunal obstruction. Atresia. Jejunal stenosis. Causes of mechanical intestinal obstruction. Low obstruction. Distal small bowel. Ileal atresia. Meconium ileus. Uncomplicated. Complicated. Colonic obstruction. Dysmotility states. Meconium plug 1 to 500 to 1000 live births. Small left colon syndrome, rare. Hirschsprung's disease 1 to 4000 live births. Colonic atresia. Anorectal malformations 1 to 4,00 to 8000. Reliable S/SX of high obstruction. Localized distension. Upper abdomen. Generalized distension. Algorithm patient diarrhea. Imperforate anus generalized / abdominal distension. Generalized / diffuse. Localized. High obstruction. Low obstruction. In a newborn patient with suspected neonatal intestinal obstruction, what is the most cost-effective initial procedure? On. High obstruction. Plain abdominal film. Upper GI series, low obstruction. Contrast barium. What are reliable signs and symptoms? More than 90% certainty that a newborn patient has intestinal obstruction that needs operation. Signs of peritonitis. Clinical deterioration. Unequivocal clinical evidence of obstruction. Radiographic evidence of obstruction. MATI, neonatal intestinal obstruction. Surgical directives, pediatric surgery. 2003 313 to 316. Treatment goals. Neonatal intestinal obstruction. Identification of cause. Relieve the obstruction. Restore bowel continuity, if stable. Gastrointestinal bleeding in newborn. Causes of upper GI bleeding. Hemorrhagic disease of the newborn. Stress gastritis. Systemic illness. Causes of lower GI bleeding. Hemorrhagic disease of the newborn. Necrotizing enterocolitis. Presence of systemic illness. In a newborn patient with neonatal gastrointestinal bleeding, what is the most cost-effective initial procedure? Vigilant observation/examination. Treatment goals. Identification of cause. Control the bleeding. Treatment of upper GI bleeding. Hemorrhagic disease of the newborn. Self-limiting. Give 1 mg VTK. Swallowed maternal blood. Stress gastritis. Nasogastric suctioning. Lavage. H2 blockers. Treatment of lower GI bleeding. Anal fissure. Stool softeners. Rectal dilatation. Necrotizing enterocolitis. Antibiotics. Bowel rest. TPN. Malrotation with volvulus. Emergency surgery. Meconium peritonitis. Perforation reliable S/SX paraclinical diagnosis. No reliable signs of perforation. Abdominal distension is a clue for perforation. Paraclinical diagnosis. Plain abdominal film, Meconium peritonitis, is a chemical or foreign body reaction of the peritoneum to prenatal perforation of the intestinal tract. The perforation may sealed off before birth or it may persist. Etiology: Meconium ileus, vascular compromise. Atresia or stenosis, intussusception. Volvulus, congenital bands etc. Intestinal obstruction. Intrauterine intestinal perforation. Intestinal perforation: Meconium leaks into peritoneum. Peritoneum will exhibit rapid fibroblast proliferation. Fibroblastic adhesion envelops the lesion. Pseudocysts. Increase vascularity and formation of mature collagen. Foreign body granulomas. And calcification develops. 4 pathologic types: type I meconium pseudocysts. Perforation not sealed in utero. Fibrous cysts wall formed from the surrounding bowel loops. Gangrenous segment of the intestine is a major part of the cysts. Rest of the intraperitoneal cavity devoid of adhesions. Calcifications may line the walls. 4 pathologic types: type II plastic generalized meconium peritonitis. Widespread spillage of meconium throughout the peritoneum. Scattered peritoneal calcifications. Dense fibrous adhesions. Intestinal obstruction occurs due to adhesions. 4 pathologic types: type III meconium ascites. Perforation occurs shortly before birth. Meconium stained acidic fluids. Fine stripped calcification may be present. 4 pathologic types: type IV infected meconium peritonitis. Perforation that did not sealed off before birth. There is colonization of neonatal gut allows bacterial peritonitis. Air and meconium present in the peritoneal cavity. The most serious type of meconium peritonitis. Clinical presentation: 1 in 35,000 live births. Intestinal obstruction is the most common presentation. Vomiting may be present on the first or second day of life. Plain abdominal X-rays shows intestinal obstruction and intra-abdominal calcifications. Indications for operation: intestinal obstruction, persistent intestinal leaks. Specific indications: X-ray evidence of intestinal obstruction and intraperitoneal air. Abdominal mass and cysted meconium. Localized or generalized cellulitis of the abdominal wall. Sepsis. Goal of management: remove all devitalized tissue. Preservation of adequate length of bowel. Re-establish bowel continuity. Abdominal wall defects in newborn. Gastroschisis. Congenital defect of the abdominal wall. Right of the umbilicus. No sac or membrane covering the midget. Omphaloceal. Congenital defect in which the abdominal viscera remain herniated. Covered with sac. Etiology. Failure of the lateral portion of the abdominal wall to join its upper and lower component. Failure in the muscular migrating from the dorsal myotomes invade the splanchna pleura of the embryonic abdominal wall. Goals of treatment. Close defect. Prevent dehydration and electrolyte imbalance. Return of bowel function. Treatment. Primary abdominal closure. Prevention of dehydration and electrolyte imbalance. Omphaloceal. Congenital defect in which the abdominal viscera remain herniated. Covered with sac. Paraclinical. X-ray. AP/L. Lateral, presence of presacral gas. Paraclinical for GI bleeding. Hemorrhagics. Necrotizing enteroculitis. X-ray. Clinical with a background of aseptics. Paraclinical for perforation. X-ray. Plain abdomen upright. Etiology. Incomplete fetal growth and fusion of the cephalic, lateral and caudal tissue. Usually present with congenital giardia. Prevent dehydration and electrolyte imbalance. Treatment goals. Close defect. Prevent dehydration and electrolyte imbalance. Return of bowel function. Treatment. Primary closure of the defect. Abdominal trauma in newborn. 25% of total trauma victims are children. Blunt abdominal trauma, most common, abdominal trauma. What are reliable signs and symptoms? More than 90% certainty that a patient with abdominal trauma needs urgent operation. On. Hemodynamic instability. Definite, persistent, progressive, direct. Tenderness with at least guarding. Abdominal rigidity. Abdominal trauma. Most common causes: birth canal trauma, vehicular accident. Abdominal trauma. In a newborn patient with suspected blunt abdominal trauma, what is the most cost-effective initial procedure? Ultrasound. Clinical questions. 9. What are reliable symptoms and signs? More than 90% certainty that a patient has perforated abdominal viscous that needs urgent operation. On. Definite, persistent, progressive, direct tenderness with at least guarding. Abdominal rigidity.